very common for patients who have atrial fibrillation, who have diastolic dysfunction, left heart disease in general, to be associated with pulmonary hypertension. The treatment, the approach is somewhat different than the PAH that we talked about. Patients with chronic lung disease, with the damage, with the hypoxia, they can be associated with pulmonary hypertension. But again, this is something that's not amenable to therapies specific for PH. We try to optimize their underlying disease, and the mechanisms are various, from cigarettes, from hypoxia, from hypercapnia, that can cause endothelial dysfunction and endothelial injury with elevation in the inflammatory markers, and sometimes alteration in the systems that we talked about, the prostacyclin, the nitric oxide, and the endothelin, and eventually it will lead to the pulmonary hypertension as such. We talked about the group 4, which is associated with PEs and the chronic PEs. The patients will have obstruction in their pulmonary circulation, and this will definitely lead to increase in the resistance, and the treatment is completely different. This is a surgical disease that you have to refer to a specialized center where they will open the pulmonary artery and take the clots out. It's very relevant. We see a lot of cases with CTEPH in our part of the world that still consider pulmonary hypertension. The approach and the treatment might be different, but the presentation can be the same. And if you don't look for CTEPH, sometimes you will miss it and you treat the patient as pulmonary hypertension. And the clots that comes out of these patients after surgeries, all these patients are actually our patients from the clinic that they underwent surgical treatment, and these what comes out of them. And of course, after you take this out of the pulmonary circulation, their PVR, their resistance decreases, and they improve, and they even to the point where they stop all their therapies. The group 5 is a heterogeneous group of patients that can be collected from hematological malignancies. In our part of the world, probably sickle cell disease can be associated with it. It has specific features that not fitting the proper pulmonary arterial hypertension picture, so that's why they put them together, and usually these are somewhat rare diseases that you probably don't have to worry much about them. So the way we understand it, that there is a vascular injury from whatever cause, pre-genetic disposition, maybe some infection, maybe some autoimmunity, that will lead to like endothelial cell injury and damage, inflammation, cytokines, and cellular infiltration, to the point where it will lead to the development of the disease. Patients, after having this process, I don't know how long does it take, but definitely it takes months before it develops. Patients will start feeling shortness of breath. These are the common symptoms that the patients will present with. Chest pain, syncope, all of these can be associated with pulmonary hypertension, none of which is relevant. But they do become relevant when you put it into context. When the family history, for example, patients who have pulmonary hypertension, they might be having familial pulmonary hypertension. Wallahi, a patient comes to you and her mom has pulmonary hypertension. The probability of these symptoms to be explained by pulmonary hypertension becomes higher. If a patient that you know, he is a drug addict and he's taking amphetamines and he's coming complaining from shortness of breath, the probability of this might be associated with PH is not there like great, but it is a possibility. A patient comes to you with no history and they are having a little bit of coughing, a little bit of shortness of breath. Asthma is much more common disease. Maybe allergies, maybe something related to a pneumonia. Maybe there are common diseases that you should think of first before you think of pulmonary hypertension. But when the picture does not fit, or when they do have an associated disease that puts them at higher risk of developing pulmonary hypertension, I think that should be getting a little higher on the differential diagnosis list and should be kept in the mind. Physical exam, again, you examine the patients, it will really be very bad to diagnose a pulmonary hypertension patients by physical exam. By then, the changes are very advanced and the patient is probably in trouble. But every now and then, you will see a patient who does have very loud P2, which is the second component of the second heart sound, the pulmonary component of the second heart sound. And sometimes they do have classical features of right-sided failure. They have JVP, they have ascites, they have lower extremity edema. Again, now we don't see these patients in the clinics, regular clinics, primary care clinics as much. They either come to the emergency room or they just die in the process before they get diagnosed. So by the time you have a very specific diagnosis of PH by physical examination, things has been really been going on for some long period of time. Sometimes we do ECGs commonly available in the primary care clinics. The ECG can be very trivial, like this ECG of a PH patients, and sometimes it can be very, very abnormally looking. You have right bundle branch, the patient is young, and why would he have this? The patient is having symptoms that are suggestive of pulmonary hypertension. You cannot ignore that this might be the cause of all their representation. X-ray is another common modality we do. I don't want to talk about all the diagnostic workup because next lecture will talk about this, but the X-ray can be subtle like this one, or it can start showing enlargement of the heart. You can see patients with having prominent pulmonary vasculature. This is, nobody can miss this as pulmonary hypertension, and this another patient who really have severe pulmonary hypertension with their pulmonary artery. Again, these are advanced features. By the time the pulmonary artery starts showing on the X-ray, the patient has had this for a significant amount of time. We talk about this disease because it's bad, although it's rare. We do estimate the PAH to be between 25 to 50 people per million per year. Saudi Arabia has 30 million people, so you make the calculation. We don't have that many patients, not all of them diagnosed. Still, a lot of them, probably 2/3 of them, are still not diagnosed. And every year we are expecting a new flood of patients into the system, although rare. But when you look into the collective large number of population, you will start picking them up. The mortality or the outcome of these patients at large is not great. We're talking about somehow young patients. Our average PAH patient in the kingdom is around 36, 37 years old. In the West, they might be a little bit older, but in our registry, it shows young people in the registry, and their probability of survival will change according to their underlying disease that's causing their PH. And, probably the best is congenital heart disease, but definitely the idiopathic, the associated with connective tissue disease is really bad, and it can be, a problem. Now, with therapy, things has improved, definitely. If you look in the graph in the middle of it, this is the initial data before therapy. People at 1 year, only 68.2% survival rate. Now it reaches 90%. That's great. But look at what happens down the line. In year, let's say 3, you are talking about 30-year-old, 35, 40-year-old. After 3 years of diagnosis, a quarter of them are dead, which is something that's considered high if you want to talk about the mortality percentages and the probabilities in this population. And this upper graph is with therapy. There is room still to improving, and probably early detection and diagnosis can make a difference, because it was shown in all the studies that the earlier you pick the patient on and the earlier functional class they are in, the better outcome they have. And if you look at this, you will see the patients who are in functional class 4, they tend to do the worst. And this is people who are presenting sick, very sick, they are dead. And the ones who present with functional class 1 and 2, they tend to do better, which makes sense. This is from Australia, and unfortunately, their number indicates that it takes an average about 47 months to diagnose a PH patient, between them being seen by a primary care physician until they get diagnosed. And of course, the majority of them, they were in earlier functional classes, and by the time they got diagnosed, they are in functional class 3 and 4. The program that we're having tonight and similar programs are intended to increase the awareness so that we can pick up on these cases sooner. And setting the stage for the next diagnostic lecture, I wanted to share with you a couple of cases, very quick ones, to show you. This patient is a nurse at KFMC. She is working with us, and one day, this is her employment X-ray. It was passed as normal. I think she had some difficulty breathing in 2011, and she did have this X-ray. Nothing happened. It was missed completely. 2013, this X-ray. I saw this patient back then. She was an ER nurse, and we looked into her quickly because she was having symptoms in the emergency room, and this was her ECG. We did a CT scan for her. She did not have a PE, and her echo showed dilated chambers. You will see more echoes in the next lecture, but the idea is that she was having very advanced pulmonary hypertension, and when we did the right heart cath, her mean pulmonary artery pressure was 62, which is considered very high. So again, this patient was missed on multiple opportunities that has been seen by primary care physicians, by emergency room physicians, and until she was seen by, just happened to be me, and we managed to diagnose her. This is another young patient in her 20s. She started having symptoms. She went into a cardiologist. She's out of town, and she was preparing for her marriage. She was to be married within 2-3 months, and they told her that you might have difficulty with breathing because you are excited, you're busy, you might have some problem with the heart. They did an echo, they saw some pulmonary hypertension. They said, okay, we'll work you up after you finish your stuff, you go get married, life is good. She comes to our emergency room with this echoes, very bad, very dilated right side of the heart, and that happened about 2 months after her marriage, which is the total duration of about 3.5 months or so. And unfortunately, her ECG was bad, showing right-sided ischemia and basically on the verge of right failure. And her PA pressure was extremely high. She was having very severe disease. on diagnosis. This is something that we are trying to prevent and trying to avoid if we could. I think we might have some time later on to discuss if you have any comments, but go ahead and write them in the chat. I will answer all of them, and if we have time to open the mics for you, we will do that. It's my pleasure to introduce Dr. Abdullah is going to be talking to you about the diagnostic algorithm of pulmonary hypertension and specifically talk about the things that are reasonable and the things that you don't have to worry about in your clinics when you come across a PH patient, at least by screening tools. Dr. Abdullah is a cardiologist at King Fahd Medical City. He's an interventionalist and he does have a very good experience and training in pulmonary arterial hypertension. So Dr. Abdullah, please.
Thank you very much, Hassan. Welcome, everyone. Let me just share my slides. All right, so I was assigned to talk about how we make the diagnosis of pulmonary hypertension and when is it not necessary to do the full workup. So these are my agenda for today. We'll discuss the role of screening and then the diagnosis and the diagnostic modalities, echo versus cath. And finally, we'll touch base on certain scenarios where the full workup is not really required. And the reason we say full workup is not really required because, as Dr. Hassan mentioned, we have pulmonary hypertension, which is a big group of patients, including group 1, 2, 3, 4, and 5. And this is a very large, we have lots of patients with pulmonary hypertension, but not everyone is considered to have pulmonary arterial hypertension. And those are the particular group where treatment is beneficial. So we try to identify those out of the large chunk of patients with pulmonary hypertension. So why do we do screening and what is screening? So screening essentially it is an early detection of asymptomatic patients who are carrier of a disease. And the reason we are interested to do screening is because in general, as Dr. Hassan mentioned, there is a delay in the diagnosis of symptomatic patients, let alone those who are asymptomatic. And symptomatic patient, it takes up to 2 years for them to be diagnosed. So the problem is, initially PAH is a clinically silent disease. And by the time patients are symptomatic, like we saw in these X-ray examples of Dr. Hassan, it's already too late. And there is already an extensive remodeling and obliteration of the small pulmonary arterioles. So probably it is too late to wait until the patient is symptomatic to make the diagnosis. So what do we do? So the other thing is the initial symptoms of pulmonary hypertension are very mild and nonspecific. Dyspnea is very common. It can be related to excitement of a marriage, like has been, or lots of different reasons. Again, syncope has multiple different reasons. People, when they have syncope, they think of either vasovagal or like some electrical abnormalities of the heart. So the first take-home message that I'd like you to take out of this is that PAH is rarely suspected until it has reached an advanced stage and prognosis is poor. And most of those patients, they have symptoms way before, like they are symptomatic way before they are diagnosed. So the hope is we try to detect and diagnose those patients early, and with early intervention we can prevent that RV from remodeling irreversibly. So at least we can have a patient who has no functional impairment and no irreversible disease. So that's the hope, and that's the whole reason why we should discuss screening and early diagnosis. Sam showed this slide a little bit more detail. So by increasing awareness, what we're doing today is hopefully we're sending a message about the signs and symptoms of pulmonary hypertension, about the risk factors, about the different etiologies, and how we treat, treat those patients. And hopefully by this, we can detect more and more patients. We can screen those who are high risk. And when we make the diagnosis, we can initiate an early treatment, and hopefully we treat them to target, as Dr. Shaya is going to show us. And hopefully all of this is going to improve the long-term outcomes. So Screening is not for everyone. We screen someone who is asymptomatic and who is at risk for preclinical disease. And we learned from medical school that screening has to be non-invasive, because you cannot screen with right heart cath. That's a pretty invasive procedure. It has to be accurate method, and it has to be associated with a high negative predictive value. And then should be a cost effective. It shouldn't be something very expensive. So how can we screen for PH in general, or PAH? So any physical exam basically is a screening. So when you see an asymptomatic patient in a primary care setting, and you put your stethoscope in their chest, that's by itself is a screening. If you hear loud S2, or a murmur of tricuspid regurg, or RV heave, then this has to trigger something in your mind that probably there is some underlying thing that we need to discover, and further workup is required. We can screen with echocardiogram in particular scenarios. We can screen with ECGs if we see like unexplained right bundle or unexplained RVH in an asymptomatic patient. This warrants further investigation. And we can also screen with circulating biomarkers like BNPs. So who do we screen for? Pulmonary hypertension? So anyone who's at high risk. Who are those? So anyone with connective tissue diseases, SLE and scleroderma, anyone with significant family history of pulmonary hypertension, congenital heart disease, HIV, portal hypertension, history of any of the drugs that have been shown to be linked to pulmonary hypertension, patients who have recurrent VTEs or PEs with symptoms, and seculars as well. Let's shift gears into how do we make the diagnosis now. And echocardiogram is the first modality of choice when we want to investigate or screen for pulmonary hypertension. And echo, there are two main things that we look at. There is the 2D findings, and there is the Doppler finding. So by 2D, it's the image that we see. It's a moving image. And there are specific criteria to diagnose RV hypertrophy or dilatation. We can see that the RV is bigger than the LV, and this creates a so-called D-shaped septum. We can look at the right atrium size. We can look at the dilated pulmonary arteries. So that's one way of diagnosing pulmonary hypertension on echo. There's probably the most important one is the Doppler effect. So basically what Doppler is imagine you're like standing in a street and you hear a siren of an ambulance siren coming from far away. So the sound, you can really get a sense of how far and how fast the ambulance is by the pitch of the sound. So if it's coming closer to you, it means probably faster. And so if the sound is high pitch, then it's probably is coming closer towards you, and it's faster than a low pitch sound, which is probably going away from you. So the pitch of the sound will let you know how far and how fast the moving ambulance is. That's basically the same concept of Doppler. So in Doppler, the ultrasound machine sends waves, and then this wave gets reflected by the moving blood cells, RBCs. And from that, you can determine the velocity of these RBCs. And if we determine the velocity, we can change that into, through mathematical equation, into pressure, and we can estimate the pressure inside the RV, which is essentially the same as the pulmonary pressure in the absence of any obstruction between the two chambers. So this is an example of a tricuspid regurgitation velocity. And we can determine the speed of these RBCs when they're being regurgitated into the RA. And if we know exactly how fast they are, we can change that from velocity into pressure, and we can estimate the pulmonary pressure. So on the top left-hand side here, we see TR velocity is 2.86 meters per second. And that can be translated into a pressure gradient of 32. You add it to the RA pressure, and we get an estimated pulmonary artery pressure, systolic pressure of around 40 or so, depending on the IVC. And so those are detailed. I don't think it's the scope of this lecture to go on how we actually do that, but that's basically the concept. So as I said initially, there is pulmonary artery hypertension, and those are where the problem is in the precapillary, so these are the pulmonary arterioles, and we have pulmonary hypertension, and this includes PAH as well as PH secondary to left heart disease. So can we tell from echocardiogram the difference between the two? The answer is yes. There are some findings on echocardiogram that will tell me this is most likely precapillary, and there are findings that will tell me there is most likely postcapillaries. Again, probably this is too deep for this talk, but the whole point of this is that on echo, we can get a sense of the etiology of the pulmonary hypertension, not accurately, but we get a sense what is causing the high pulmonary pressure. Is it a left heart disease problem, or is it something precapillary problem? So if it's a left heart, we call that post-capillary pulmonary hypertension, and if it's before, then we call it precapillary, and right heart cath is the way to differentiate. We'll come to that in a second. So these are the findings that will tell me this pulmonary hypertension, and most of these are usually mentioned in the echo report, but probably the most important one is the LA enlargement. If your left atrium is enlarged and the left ventricle is thick, then and there is evidence of diastolic dysfunction, then most likely this degree or this elevation in pulmonary pressure is due to left-sided problem. So on echo, we can get a few things that will tell us how accurate or how certain are we about this pulmonary hypertension. So we can look at what's called RVSP, or the tricuspid regurg velocity, and that's probably the most important thing. If it is less than 2.8, which is translated into pressures of less than 30, then probably you don't have pulmonary hypertension. So your echocardiographic probability of pulmonary hypertension is low. So if the velocity is high, above 3.4, then you most likely are going to have pulmonary hypertension. If it's in between, then you have to go and look for other echo signs of pulmonary hypertension. What are these echo signs? So you look at the RV-LV ratio, you look at the what we mentioned earlier, the flattened septum or the D-shaped septum. You look at something called acceleration time across the pulmonary valve. You look at the inferior vena cava and make sure it's collapsing or not. So all of these are suggestive sign of echo. You use them when you're in the intermediate range. The velocity is between 2.8 and 3.4. All right. Now, if we diagnose someone with pulmonary hypertension based on echo, do they need to go for right heart cath? What do we do with those patients? So it really depends on two things or three things. One is, are they symptomatic or asymptomatic? That's number one. Number two, do they have how high the echocardiographic probability of pulmonary hypertension? And number three is, do they have risk factors for pulmonary artery hypertension? So three things that will determine what to do. So let's take an example of someone who is asymptomatic and who has a low echocardiographic probability of pulmonary hypertension, but they do have risk factors. Let's say they have connective tissue disease. So what is basically recommended here is an echo follow-up every year or so, and that's a class of recommendation 2B. Let's take another example. Someone who has connective tissue disease, like a scleroderma, they have an echocardiogram which showed high probability of PH, and they have symptoms of PAH. So we go and they are here, and we see that a right heart cath is recommended. So basically use this from the 2015 guidelines to help you decide what to do with those echoes that have shown some degree of pulmonary hypertension. So three things: symptom status, how strong the echo probability of PH, and we do that based on this table as we just mentioned. And then number three is, does the patient have risk factor for PAH or CTEPH? And again, this table shows you the same thing, but in symptomatic patients. So basically, again, you just come up with examples or different patient scenarios, and you will be able to see what is the recommendation, what to do with the echocardiogram, and where to go from there. Now, there are certain patients that you really want to fast track them to a expert PH center. And what do we mean by that is, you want to call someone or facilitate the transfer, because it really is in the patient interest if you send them right away to an expert center where the workup can be facilitated and expedited. Who are those patients? Those are the family history of pulmonary hypertension. Those are who are known to have genetic mutation of PAH. We talked about BMPR2 earlier. The patients with risk factors for PAH. If you're suspecting PVOD, or if there's pulmonary hypertension and the probability of left heart disease is very low. All right, so there are two groups of patients that when you see their echoes showing pulmonary hypertension, you should probably think before you send them to further investigations. Who are those? So number one is group 2, and those are the patients with left heart disease. So with left heart disease, what we're saying is either ventricular problems, or either reduced ejection fraction or preserved ejection fraction, or a valve problem, either an aortic or mitral valve problem. So the other group is those patients who have a clear and advanced lung disease that can explain their underlying pulmonary hypertension. So, and the reason we don't want to do a lot of expensive workup on those patients is if you are making the, like if you're certain that they have these underlying etiologies, then we know that targeting pH therapy or targeted pH therapy is unlikely to be of any benefit, or if anything, it is probably harmful to treat those patients. So that's why we reserve investigations to those patients who have low probability of these conditions. So who is a patient? An example of a patient who has high probability of a left heart disease. Elderly patients, those who have metabolic syndromes, obese, hypertensive, diabetics, those who have prior cardiac interventions, either PCI or CABG or valve problem, AFib patients. If you do their ECG and you find a left bundle or LVH, again, we talked about the LA dilatation, look at your diastolic function on echo report. So those are patients that have probably high probability of left heart disease, and further workup is unlikely to be beneficial in those type of patients. So, so we've shown you how echo can make the diagnosis, but why do we really need the right heart cath if echo can give us an idea about the RVSP or the pulmonary pressure? So the first reason is, on echo, we cannot really measure pulmonary artery wedge pressure. And we know that that's the main differentiator between pulmonary, precapillary and postcapillary. So if you have low wedge pressure, this is a precapillary problem, and those are the type of patients that will benefit from treatment. If you have high wedge pressure, those are the patients that are unlikely to benefit from the treatment. So it really makes a difference. Echo can be inaccurate in estimating the pulmonary pressure. Echo, again, can give us cardiac output and PVR, but it's not as accurate as the hemodynamic and invasive assessment. And again, echo assessment of the RV function is not straightforward. It can be done, but it's not straightforward. It's probably better to get a sense of the RV function from hemodynamic assessment and cardiac output estimation. So we do right heart cath, number one, to confirm the diagnosis and to differentiate WHO group 2. That's probably the most important reason. Number two, we do right heart cath to assess the severity of the hemodynamic impairment. Number three, we do it to follow up and to assess response to medications. Number four, we'll come to that. We do it to assess vasoreactivity, because there are certain patients that are vasoreactive, meaning they have a different pathophysiology of pulmonary hypertension that can be treated with calcium channel blockers instead of the other medication. We do right heart cath to assess for congenital heart disease. We'll have a talk about that by Dr. Omar Tamimi. And we also do it to assess for technical suitability of or to diagnose pulmonary and chronic pulmonary hypertension, CTEPH, and also timing of heart transplant and before lung transplant as well. We can also, when we do right heart cath, we add the left heart cath to, again, those patients who have signs or symptoms of coronary artery disease. We can shoot their coronaries at the same time. And in cases where the wedge pressure is not really clear, we can assess the filling pressure by direct LVEDP measurement. So what do we mean by right heart cath? So basically it's a procedure done in the cath lab, very low risk procedure. We should, it gives us hemodynamic tracing, and also basically we can do it from either femoral, brachial, or jugular veins. We put something called the Swan-Ganz catheter, and we use up to like between 5 and 7 French catheters. These are balloon tipped catheters that go and help us determine what is the wedge pressure. And then we can also do a shunt run to look for any left to right shunting. And again, as I said, we can at the same time do coronary angiography in patients who are at risk for coronary artery disease. So why do we see sometimes a conflict between right heart cath data and echo data? There are multiple different reasons. Most of the time, they don't occur simultaneously. So, and we know that pulmonary pressures are not like a fixed number. They vary according to volume status, according to oxygenation status, according to multiple different things. So that's probably one reason. We know that echo is not very accurate, especially if you don't have a good signal of tricuspid regurg. And then on the cath lab, we also give sedation, we give oxygen, which may reduce the pulmonary pressure, which is not the case in echocardiogram. This is the reversibility testing to detect those patients who have vasoreactive pulmonary hypertension. It is important to do those in the right patient population. There are criteria for those patients. And if you diagnose it, then treatment is completely different. There are criteria for this that I think is beyond the scope of this lecture. Finally, as I said, we can use the right heart cath to do pulmonary angiogram. This is a beautiful example of the pulmonary arteries that we can sometimes use to detect if the or to determine if the patient needs pulmonary endarterectomy surgery if they have underlying CTEPH. So we'll finish with this. This is the suggested algorithm from the guidelines. So as we can see here, we have someone with history, symptoms, signs of pulmonary hypertension. Then you start with the echocardiogram. If the echo says low probability, then you just look for other reasons. If they say high or intermediate, then if they have the conditions that we mentioned, need fast track to pulmonary hypertension, then please go and refer them to expert centers. There are multiple expert centers in the kingdom, in almost في الرياض, في جدة, في الشرقية, في الجنوب. There are multiple PH experts around the kingdom. Now, after your echoes,
I think we lost your sound, Abdullah. Can you hear me? Abdullah, you're muted.
I can hear you now. Let me
Okay.
just.
Okay, you're muted.
I'm sorry. So I'm not sure where I was which part did you hear, but basically we'll just go over it again. So if you have low echo probability of PH, then you just look for other diagnosis. If it's high or intermediate, if the patient meets the criteria for fast track, please go ahead and refer them to your nearest PH center. If they're not, then go and do can't look for CTEPH, and then have a pretest probability of left heart disease, as we mentioned. Does this patient have risk factor for left heart disease? If the answer is no for both, and there's also no reason to think that this patient has severe underlying lung disease, then you can make the diagnosis and refer them to a PH center for further workup. But if they have left heart disease or significant lung disease, then probably that can explain the reason, or the reason behind the PH, and further workup is unlikely to be of value. However, there are cases where you really are not sure, and again, those are the cases where we think referral to a center where they see a lot of PH patient is going to be beneficial. So with that, I would like to conclude, and I'm not sure if we can open it for questions or we leave it to the end.
Yes, Abdullah.
Maybe I'll introduce Dr. Shaya then. Dr. Sami, we go ahead and
Sure.
go to the next.
So go ahead. It's okay. Now we are one team. So the next lecture will be with Dr. Shaya. I think go ahead, introduce him.
Dr. Shaya is a dear friend and colleague. He's a pulmonologist and the program director for the Pulmonary Fellowship Program at R2, and also the deputy program director for internal medicine. Very interested in teaching and education, and he's an excellent PH and pulmonology physician that I happy to work with on a regular basis. And he's going to talk to us today about how we treat patients with PH and how do we risk stratify those patients. Dr. Shaya.
Assalamu alaikum, مساكم الله بالخير جميعا. Have you seen my slides?
Yes, we
clear, Shaya. Go ahead. We can see.
So thank you for organizers, thank you for the committees, thank you Dr. Hussam, Dr. Abdullah, and Dr. Umar for the nice introduction. I'm really glad to be with you today, and I'm one of the like elegant expert, Dr. Umar, Dr. Hussam, and also Dr. Abdullah. I'm really glad to be one of them to be presented today. So talking about pulmonary hypertension is always advanced. So our aim today to talk about the pulmonary hypertension in simple and make it easier for everybody to understand and try to make you not too scared when you see a patient with pulmonary hypertension. And also talking about advanced pulmonary hypertension and therapy is also another difficult topic to deal with and to be discussed with. So my aim is to touch base the important algorithms, the important topics, and also schedules about pulmonary hypertension and treatment. So I will try to highlight the important things rather than go to the scientific details and ideas. So just some highlights about pulmonary hypertension, about what have been mentioned already in the beginning. So it is uncommon diseases with limited awareness. This will lead to delay in diagnosis, delay initiation of therapy, and unfortunately potential of clinical outcome, a worse outcome, and death in pulmonary hypertension. The problem with pulmonary hypertension patients came at a time where there is declining and decompensated conditions. And this is a problem when we see this patient coming late to the pulmonary hypertension experts and centers. So we have a problem to push the patient again back to pre-symptomatic or symptomatic, at least decompensated part in this condition. Most of the time we see the patient when there is decreasing in pulmonary cardiac output, as well as high pulmonary vascular resistance, and the pulmonary artery pressure is always make people confusing where there is decreasing or decreasing in the right side or the left side, whether it is good things or bad things. So we have always to consider, is the patient is sick or not before determine the next step of treatment. Again, just to remind you about the pulmonary hypertension, this is the latest classification in the World Symposium Pulmonary Hypertension in 2018 in Nice. So the first group is pulmonary arterial hypertension. Previously, we called primary pulmonary hypertension. Now it's pulmonary arterial hypertension group 1, which include different type of causes. One of them is idiopathic heritable drug and toxins, then associated condition like connective tissue disease, HIV, portal pulmonary congenital heart disease, and schistosoma. Then one of the important things, new thing in this guideline has been added long-term responder to calcium channel blocker. They thought it is a new entity and a separated entity, sorry. And then the BVOD, BCH, and newborn syndrome and persistent pulmonary hypertension. Group 2 pulmonary hypertension is a left heart disease related pulmonary hypertension. Is a backflow pressure responding in pulmonary arterial and pulmonary pressure. So it's increased secondary to this underlying cause. So left heart disease secondary to preserved left ventricular ejection fraction with reduced left ventricular ejection ejection fraction, valvular diseases. Group 3 is related to lung diseases.
Shaya, the slides are not moving. So if you share your screen and enlarge the presentation.
Have you seen the screen now, Dr. Hassan?
Still, it's on the first slide.
Okay, let me just stop sharing again. And now, is it moving?
It's not moving. I think you should share the screen itself and enlarge your presentation. And you go to the mode of.
I did, but I didn't know why. Let me stop sharing again and see if this can work again or not. Can you see the screens?
We see it, but are you moving the slides?
Yes.
It's not moving.
Okay. So you can see the screen.
Now it's we're just clicking on them. Just keep going down. Yeah, so the slides are moving. Okay, we can see them. Try to enlarge it. Go to the like no. Go to the show. Yeah.
ما مشت.
It's not work. It's not.
Is it moving now?
Try to see. Let's see if it will enlarge. But it was moving earlier. Yes.
Now it's moving.
At this moment, now we see the pH due to left heart disease, pH due to lung disease, the classification.
Maybe I can keep it like this way.
Sure. If you move it one slide by one, that's fine.
Is it okay like this?
Yes, go.
Saving other people time, so I think I have to keep it this way. Inshallah أنها بتكون واضحة. So group 3 is related to lung diseases, either obstructive or restrictive lung disease, sleep apnea, and so on, COPD, and interstitial lung disease. Group 4 is related to underlying pulmonary arterial obstruction, either because of chronic thromboembolic disease or other causes like masses or so on. Group 5, where there is specific diseases, has no clear criteria where we can put them on. So either they are group 1, 2, 3, or 4 related picture of causes. So either it is like hematological diseases, metabolic diseases, chronic kidney disease, hematological malignancies, myeloproliferative disorder, sarcoidosis, lymphangiomatosis, and so on. So we have to understand that all these causes, the 5 groups is called pulmonary hypertension, and the group 1 is pulmonary arterial hypertension, where the treatment for pulmonary hypertension is needed. All other groups had a specific way of treatment. We are going to touch base about all these things. So we have to keep in our mind most of underlying causes for pulmonary hypertension is like between group 2 and group 3 pulmonary hypertension. Group 2 left heart disease related, and group 3 lung related and hypoxia pulmonary hypertension. So we have to treat the underlying causes, and then we have to talk about group 1 and group 4 where there is specific pathway to treat pulmonary hypertension. So let's talk about pulmonary arterial hypertension, group 1, where our money is. So since 1990s, whereas the first treatment in pulmonary hypertension has been initiated with epoprostenol, till 2015, when there is different modalities of treatment, different pathway of treatment has been initiated and discovered. So the pulmonary hypertension treatment pathway is mainly 3. This is, we are talking about targeted therapy for pulmonary hypertension. The first one is endothelium pathway, second one nitric oxide pathway, the third one is prostacyclin pathway. So the first line, endothelin receptor pathway, we have to inhibit this pathway to initiate the vasodilatation and inhibit the vasoconstriction, and also to decrease the proliferation and the disease itself. As well as the same idea for nitric oxide pathway, we have 2 treatments can be used in this way with phosphodiesterase 5 inhibitors. The other one is guanylate cyclase stimulator, when we have to inhibit and the phosphodiesterase inhibitor, the cyclic GMB, 2 GMB, so we have more cyclic GMB and we have more vasodilatation and decreasing the proliferation. Or we have cyclase guanylate stimulator, so we are increasing the presence of cyclic GMB in the cells and increase the the vasodilatation, and also decrease the proliferation. The last pathway we so far discovered for pulmonary arterial hypertension treatment pathway is prostacyclin, which we have two kind of medication, either agonist, prostaglandin agonist, analogs, or receptor agonist to stimulate prostaglandin pathway and vasodilatation and decrease proliferation of underlying disease. This is the main pathway that we are working, and we have specific medication for that. So the three pathway, the main therapy has been used so far over all the world is the endothelin receptor antagonist pathway, bosentan and presentan and macitentan, nitric oxide pathway, either sildenafil or tadalafil, or a cyclic or a coagulate cyclase stimulator with rheosugate, prostacyclin pathway either by IV, evoprostenol, treprostinil, either IV or sub-Q, Alipros inhaled, or Selexibag oral. All this medication has been used from different countries to another countries, which one is available in which country. In Saudi Arabia, we have most of these medication, most of these pathways is available in the kingdom, and we can use it, all of them. It's different from center to another center. So based on what had been mentioned earlier by Dr. Hussam and Dr. Abdullah, we have a patient with sign and symptom of pulmonary hypertension. A screening pathway has been done. Diagnostic procedure has been done, like the right heart catheterization. We diagnose patient with pulmonary arterial hypertension, a group 1, whether it's like idiopathic or heritable or associated condition. So once we reach to this stage of diagnosis, we have to know exactly where is the patient exactly, meaning when we have to, what we have to start, and when we have to decide about the next step of treatment. So at the beginning, we have to stratify our patient, and there is multiple pathway, or let's say it's multiple calculators has been used in the past to look for where is the patient is. Is he in the low risk group? Is he in the intermediate risk group? Is he in a high risk group? Because when we determine this kind of patients, so we can know exactly what we have to do next in terms of treatment. And this would be in the next slide. Commonly, we are using ASCRS calculator, or risk stratification, has been published in 2015 in ASCRS 2015 guidelines, and is stratified the patient to 3 groups. Either they are low risk, intermediate risk, or high risk of mortality over 1 year. So this is based on multiple things. So when we see the patient in the first place, already we diagnose the patient with pulmonary arterial hypertension in group 1. So do we have a signs of heart failure? Do we have a progressive symptoms like it is slow or rapid? Do we have a syncope before presentation or starting the therapy? Is it occasionally or repeated syncope? What is the functional class? Some people like to say this is what is NIHA functional class, either 1, 2, 3, or 4. Then we have another factor to determine where is the patient. So we are not dependent on the patient symptom itself. We are a comprehensive looking to the patient. So by the 6-minute walk test, cardiopulmonary exercise test, PMP or pro-PMP, imaging like echocardiogram or cardiac MRI, or hemodynamics. I understand not all the centers have all these things, and sometimes we cannot do all these things at time of presentation or at time of follow-up. So we have to look for all these things. The first 4 of them is easy to detect at time of presentation or at the follow-up in the clinic. The other things, they can be done at that time of the clinic, mainly the 6-minute walk test, PMB, and images. And then we can take all these together. Let's say we have a patient with this group of lines, then we have one line here, the other line of there. Then we have to collect all these numbers together and divide it all by the number of positive criteria we have. And then you have to get 1, 2, or 3 as a number. And then you can determine whether the patient in the low risk group, intermediate risk group, or high risk group. So in the beginning, we are confirming the pulmonary arterial hypertension in the expert center. So we have to consider the general measures of supportive therapy, like oxygen. Do we need an oxygen? Do we need a diuretics, anticoagulation in certain circumstances, and so on. So if the patient naive has no previous treatment for pulmonary hypertension, where this is the first time to treat them, so we have to know exactly whether this patient is idiopathic, heritable, or drug. If they are yes, and we have done right heart catheterization with vasoreactivity, as mentioned by Dr. Abdullah, and came positive, so the calcium channel blocker can be considered at this stage. So this is the only way when we are using calcium channel blocker, if it is vasoreactive is positive in the right heart cath. And mainly we are use this test in idiopathic and heritable and drug and toxin prior to start calcium channel blocker. If we have a patient with no vasoreactivity in the right heart catheterization, we have to stratify our patient whether they are low or intermediate or high risk, based, let's say, in this ECRS guideline and criteria of risk stratification. Let's say our patient in the high risk, we have to initiate the combination therapy, including prostacyclin IV. If they are in between low risk and intermediate risk, we have to consider oral combination therapy. There is some certain of patients for special consideration, and because of lack of trials and supportive articles. So there is some people, they need to be started in monotherapy, but all the recent guideline about pulmonary hypertension supporting the using of combination therapy for certain goals and outcomes. So when we have a patient with low intermediate risk, we can start oral and combination therapy. All over, either they are high or low, whatever medication has been used at this stage, we have to see the patient again after 3 to 6 months and re-stratify them again based on this criteria. Once we have stratified the patient based on this criteria on top of the treatment, we have to discuss with the patient whether to keep them in the same medication because we are pushing the patient from the high risk to low risk or intermediate risk to low risk, or the patient is still keeping progressing. So we have to increase the treatment to add another triple therapy in this condition. And we have to see them again after 3 to 6 months to determine their risk. Again, we have to see them again to determine whether they are intermediate or high. If still they are high or intermediate, you have to titrate the treatment up to maximize to maximum medical therapy or listening for lung transplant. This is the main treatment for pulmonary hypertension. This is the main pathway for how we are managing patients. We have to stratify them, starting them therapy, then re-stratify them again, add therapy, stratify them again, add therapy, or listing for transplant, and so on. It's like a circle and goes and back with the therapy. For calcium channel blockers, we have only 3 underlying causes. If we are suspecting idiopathic, if we are suspecting familial, if we are suspecting drug and toxin-induced pulmonary arterial hypertension in group 1. If we have done right heart catheterization and vasoreactive, we can start them in calcium channel blocker. And this is the only way to start calcium channel blocker. Otherwise, don't start calcium channel blocker and pulmonary arterial hypertension without vasoreactivity. There is no benefit. Actually, you can do a negative inotropic support to the heart in such condition and may induce or worsening the underlying pulmonary hypertension. So if there is no vasoreactivity or positive vasoreactivity, don't start calcium channel blocker. And calcium channel blocker is not considered a targeted therapy in pulmonary hypertension. So what is the general measures? As I mentioned before, oxygen diuretics, digoxin, anticoagulation. Anticoagulation in the past was used one of the main treatment on the pathway. Currently, we are not using anticoagulation anymore unless they have like a group 4 pulmonary hypertension where there is chronic thromboembolic pulmonary hypertension, or the patient has atrial fibrillation for other causes, or if the patient has previous PE-DVT, but is not considered as a part of the treatment of pulmonary hypertension. And again, for other underlying causes like connective tissue disease, they need immunotherapy. So what is that targeted therapy? Most of the time, you are starting the patient in double combination therapy, and this is because improvement of time to event, meaning improvement of underlying risk of hospitalization, death, or worsening of underlying pulmonary hypertension. And this has been mentioned in the recent guidelines and also has been certified in the recent studies to use combination therapy. Most of the time we are using a group 1 pulmonary arterial hypertension with combination therapy. There's some talk about triple therapy and some talk about monotherapy. And what is the other options is sequential therapy, meaning we are starting 1, we adding 2nd, we are starting 2, we add in the 3rd, and so on. Replace or switching, there is talking about replacing one of the treatment like phosphodiesterase inhibitor by rheosugwat and shows some benefit in this regard. Then the last options we have is advanced therapy with lung transplantation. So this is the main treatment. In ARS guideline 2015, they put all the medication and the class and level of evidence, and this has been approved multiple times, as I mentioned before, ambrisentan, bosentan, macitentan, and for the other medication, pulmonary hypertension. Again, in the ASRC 2015, they are talking about the combination therapy and the level of evidence, and also about the sequential therapy and level of evidence. We didn't like to talk about this. This is not a target treatment way of talk about today. So one of the important things we have to mention about it today is the ambition trials is talking about combination therapy with ambrisentan and tadalafil, and this shows a reduce of clinical failure by 50%, and this is better than one pooled monotherapy. Servant trial using the macitentan as well as therapy as a first line shows reduced progression and hospitalization compared to others and placebo. Optima study using macitentan and tadalafil and shows significant improvement in hemodynamic functional parameters in newly diagnosed naive pulmonary arterial hypertension. Also, Gravon study using selexibag and shows reduction of clinical deterioration. Also, Replace study I have already mentioned when replacing phosphodiesterase inhibitor to rheosugwat, and also this shows improvement in functional class, ASCRS risk stratification, also improve the 6-minute walk test, and so on. Also Triton therapy is talking about using a triple therapy as initiation at time of diagnosis. This shows some parameter to be improvement in terms of hospitalization and improvement in the long-term outcome. Why we are talking about monotherapy? Because some certain circumstances we need to use only monotherapy because of lack of supportive evidence. Like in acute vasoreactivity test with calcium channel blocker, we don't need to use other therapy if there is a low risk patient with positive vasoreactivity. Patient in the past, someone start them in monotherapy, they are approaching always low risk group. Patient with PVOD because of risk of pulmonary edema or worsening of underlying diseases. So we have to initiate one by one. HIV, POPH, portal pulmonary hypertension, and corrective congenital heart disease because of lack of evidence. So all these studies not supporting the use of combination therapy. Some mild diseases and sometimes some cases like what's mentioned here and lately in 2019 about some other cases. You can take a picture from here and look into it. So in KFMC, we have all these medications currently, bosentan, macitentan, sildenafil, rheosugwat. We are intending, inshallah, to bring tadalafil as well. Also, we have epoprostenol, eviprost, and selexibag. We are trying to maybe bring treprostinil in the future as one of the treatment. Just a few words about the prostacyclin pathway treatment. We are going to talk about the level of evidence. Prostacyclin therapy, either we are using epoprostenol with IV, treprostinil sub-Q, eliprost inhaled, and selexibag is oral. Each one of them has a specific way and route of administration. So the epoprostenol is IV. The half-life is like 4 to 6 minutes max. And it needs significant burden of care, either for us and for the patient. And there is multiple risk for rebound of pulmonary hypertension if we stop the medication, and also lung-related sepsis and so on. Inhaled eliprost has a specific way of administration as well, either by using Omron or INAB machine. Also, it has like 20 to 30 minutes half-life. We are using eliprost from 3 to 6 to 9 times a day based on the patient condition and titration. Treprostinil, again, is subcutaneous therapy mainly, and half-life is like 4 hours compared to like IV epoprostenol, and this is maybe just advantage compared to the evo. And also there is a significant risk of infection at time, at site of administration and pain as well. Oral selexibag has all the side effect of prostacyclin pathway. The only advantage is oral therapy, and this is the titrating dose from 200 microgram BID till 1,600 microgram BID and so on. We have always to assess the patient risk. We have to make sure patient can access to the medical care, the vision, the cognitive, the ability to learn, because all these medication need a great attention. So pulmonary hypertension has multiple pillars, either psychological, rehabilitation, diagnostic and therapy, palliative care, social support, and so on. So it's not just adding therapy in pulmonary hypertension. We have to consider multiple things. 3 slides about the other groups, like group 4 pulmonary hypertension. It's not a thrombus, it is a fibrous tissue, collagen fiber, and so on. So this is after 3 to 6 months of treatment of anticoagulation. We have to see this. This is from one of the patients. So we have to consider 2 lines of treatment. Either the patient is operable, so we have to send the patient directly for the surgery, for the pulmonary endarterectomy, or non-operable. So we have to consider the patient for medical therapy or pulmonary balloon angioplasty. And this is based on multiple criteria. Again, group 3 PH, group 2 PH, which is left heart disease, we shouldn't start targeted therapy. We have to treat the underlying cause, as well as lung-related diseases, pulmonary hypertension. We have to treat the underlying diseases, and this is as per guideline 2015 and so on. There's some exceptions, and this is, we'll leave it for the expert center to decide about it. Another important thing I have to talk about today before I leave is I think I have the time to talk about some cases. Just in brief, we have like 8 minutes to talk about case. So try to collect all this information together. Is the screen is clear? I'll have to, let me just open it again. Have you seen the case, the new case?
Yes, yeah, we can see it.
So we have like a few minutes to talk about a case. So patient from the clinic, she is a 49 years old lady, came to pulmonary hypertension clinic, a background with SLE. She is anemic for unclear reason. She is hypothyroid. She is in treatment for all of above. She was referred from other local hospital because of echocardiogram showing pulmonary hypertension, asking for help and looking for underlying causes and possible medical therapy or treatment for such condition. So she had a shortness of breath. It started 3 years ago, and she has worsening of shortness of breath over the last 4 months. And because of that, has been referred and found to have PH in the echocardiogram. She has syncope 3 times before presenting to our hospital. No other supportive history in terms of symptoms. She is NIHA functional class 3 at time of presentation. This is my habit in the clinic. I'm going always to all the risk factor in pulmonary hypertension. I'm going one by one, like group 1 pulmonary hypertension. Do we have like connective tissue disease? The answer is yes. There is history of connective tissue disease, SLA. She's in therapy. She has rhinoid and so on. So I have a comprehensive picture about the underlying diseases, underlying condition. I'm looking for the liver diseases, drug. Do we have a history of a drug, congenital heart disease? Do we have history suggesting of schistosoma? Do we have a family history of pulmonary hypertension and so on? Then I'm asking about symptoms or risk factor related to group 2, like do we have a HFpEF, HFrEF, and so on, pulmonary edema, right sign of left heart disease? Do we have a group 3 pulmonary hypertension related lung diseases or PH, like do we have an ILD picture, symptoms, COPD picture and symptoms, smoking history and so on? Do we have a sleep breathing disorder and so on? Do we have a group 4 picture? Do we have a previous history of BE, DVT and so on? Is the patient on anticoagulation or not? Group 5 related history. So this patient has already what I have mentioned already. So taking all this information is remarkable. And we did echocardiogram for her. Left ventricle was okay. She has a flattened symptoms. Right ventricle is moderately dilated, and right ventricular systolic pressure is normal at time of presentation. Her right ventricular systolic pressure between 60 to 70, and there is no precardial effusion. And this is, as mentioned earlier by Dr. Abdullah, it looks like a high risk. We have a signs of pulmonary hypertension, plus there is increased 3R velocity indicated by the pressure. So the patient has all these symptoms. So she is lying on a high risk pulmonary hypertension. So we have to do a further workup. BMB is high. Other workup, blood work is unremarkable. Immune marker is positive for ANA and also the breast-strand DNA and anti-Smith. Other hepatitis B and C or negative. Chest X-ray, you can see the dilatation of pulmonary trunk. It's like a hint for others to see what's going on. You can see there is enlargement of right pulmonary trunk, also flattening enlargement of right side of the heart, which indicate right ventricular and right atrial enlargement. And this is just a picture. This is for another patient. You can see the enlargement for this patient and the lateral side, enlargement of the right ventricle, and also enlargement of the pulmonary trunk as well. So in this patient, she walked for 330 meters in 6-minute walk test. Pulmonary function test shows only the LCO reduction by 61%. CT scan, we are trying to rule out interstitial lung disease, so there is no evidence of interstitial lung disease. So what is the next step? We did all the workup, the initial workup, to determine what is the underlying most likely cause. So this patient has no clear underlying cause except group 1 PAH by connective tissue disease with SLE. So we go ahead with right heart catheterization because the patient has SLE, so we tend not to do a vasoreactivity because this is not an idiopathic as per history and by the workup. This is not a drug or toxin by the history. This is not a familial. We don't have any evidence of familial pulmonary hypertension, so we didn't do vasoreactivity. So we did right heart catheterization, which shows mean pulmonary artery pressure is 58. The cat limit, as mentioned by Dr. Hussam, is 20. The wedge pressure is less than 15. Here is 12, and the cardiac index is 2. And the pulmonary vascular resistance is 12. This indicates pre-capillary pulmonary hypertension. With the history, with the workup we have mentioned before, this is pre-capillary group 1 pulmonary arterial hypertension as per the guideline. And this is our diagnosis, pulmonary hypertension, connective tissue disease related PH. So what we have to do at this stage, we stratify the patient as I mentioned earlier. So this patient lying in the intermediate risk group between 5 to 10% 1-year mortality. So we go ahead with this risk stratification. So we confirm the diagnosis. This is not idiopathic, not heritable, not a drug and toxin. So vasoreactivity test hasn't been done. She is intermediate risk. We start her initially in combination therapy. We risk certificate after 3 to 6 months to determine whether she is doing fine or not. So we start this patient in combination therapy with macitentan and sildenafil. We are talking to her about the fluid and salt intake and restriction. Vaccination is important because they are sick, and we have to make sure they are decrease the risk of infection. Birth control, she is a time of possibility of getting like pregnant, so we have to double control the birth control. Treatment, we have to discuss with the patient about the side effect expected, and also they have to stay and continue to use these medications because we cannot stop that. Also, we have to control the underlying disease by immune therapy, and then we have to see the patient to certify her after 3 to 6 months. We are asking for echocardiogram, 6-minute walk test, and some blood test. And this is our mainly approach in this case. This is another case with elderly uncontrolled systemic hypertension, and he's a smoker. He has some symptoms of shortness of breath. It's just keen progressive. We talk about all these things briefly in other patient. There is RVSP is 60. I'm just trying to go quickly over this case. We have right atrial dilatation, so we have a high-risk patient based on this criteria. CT scan shows some emphysema pili in the upper lobes and some articulation in the lower lobes. CT scan as mentioned. So I'm thinking it is like maybe it's a group 3, something like that. His pulmonary function test shows FEV1 was severely reduced, FEV1 by 31%. So as per criteria of COPD, we are considering this patient as severe COPD. TLC as well as low as this in this patient. All the blood work is unremarkable. It's mainly group 3 pulmonary hypertension, right heart cath confirming pre-capillary picture, and it's just mild. Because of that, we don't treat patients with pre-capillary picture and group 3 pulmonary hypertension. At this stage, we are confirming, we are supporting the diagnosis. So is this like group 1 or a group 3? Because they are, both of them have similar right heart cath picture. So because of severe FEV1 and if we see reduction in the pulmonary function test, we consider this patient as a group 3. We don't treat him, we treat underlying cause. I just saw him maybe 2 weeks ago. I just give him like some medications for COPD, and he was doing fine, he was great. And he has no major complaint about symptoms related to shortness of breath. What about another case with 41 years old, shortness of breath, function class 4, echo severe pulmonary hypertension, CTPA shows mosaic attenuation. One of the important things that we have to do for our patients with pulmonary hypertension. We are doing a VQ scan. There is multiple heterogeneity, filling defect and perfusion defect in this patient, as shown here. So in the perfusion scan, we have good ventilation, but we have poor perfusion bilaterally, which indicates the underlying chronic thromboembolic pulmonary hypertension. Right heart cath confirming the pulmonary hypertension. So we have a VQ scan is positive. We have a patient with severe pulmonary hypertension based right heart catheterization. We consider this patient as a chronic thromboembolic pulmonary hypertension. As per guideline, we have to consider if the patient is operable to do pulmonary endarterectomy. If the patient is non-operable, we have to consider the medical therapy versus pulmonary balloon angioplasty or both of them. And then the circle goes back and forth. Thank you so much. I think, inshallah, this is like some cases, just try to like organize things together between the first and second and third lecture of today. Thank you so much.
Thank you, Shaya, so much. We are right on time. That's good. It's my pleasure to introduce Dr. Omar Tamimi, pediatric cardiologist and interventionalist. He has, you know, a long experience with PH, and he's one of the pillars of pediatric PH in the region, actually. So he will talk to us about pediatric pulmonary hypertension and things that are somehow unique features in the kids. Dr. Omar, please.
Shukran, Dr. Hussam. Welcome, everybody. And it's my pleasure to talk about the pediatric pulmonary hypertension, and as it's an unique and feature and special consideration for patients with pulmonary hypertension. Surely that I'm lucky to talk about all these big names like Dr. Hussam, Dr. Shaya, and Dr. Abdullah. And really, half of my mission was covered by them. So I'm just completing the thing which is not covered by them, or just repeating some of them, so that to help the people to understand what we are talking about in the pediatric side, which is usually, as usual, you know that pediatric is not a small adult, and usually we have special consideration. We are dealing with these small babies. So in the pulmonary hypertension, it's a complex in the pediatric, and usually the problem with the pulmonary hypertension, it's having different causes. Some of them is transient, and some of them is a progressive diseases. And most of the established pulmonary hypertension medication therapy, which is used in adult, we use it, most of them in pediatrics. And usually when you are talking about PH, is the progressive type, is more or less you are talking about the same prognosis in the adult, as most of them, they are going to have a mortality and morbidity. And of course, if they are lucky, they will end by lung transplant. So the other problem with the children is that in idiopathic type, that they are progressing faster than the adult type, and most of their survival is 10 months, as opposed to 2.8 years for adult when you are not starting any medications. The definition of pulmonary hypertension, we are using the same number with the adult. We are using the mean of more than 20, but in children, we should be waiting until the age of 3 months. Before 3 months, it's very difficult really to define it. But most of the people that are in below the 3 months, you are using the echo criteria, and the minute you are more than half of the RV system, systolic pressure, more than half of the systemic pressure is usually considered as pulmonary hypertension. And the pulmonary arterial hypertension, we are adding the BPRI, which is indexed for the children with more than or equal to 3 Wood units. The others for single ventricle, you know that we are using the transpulmonary gradient. If you have it more than 6, it's usually as significant. If in the mean PA pressure less than 20, and also the BPR is more than 3 Wood units per meter square. As Dr. Hussam mentioned, and that the mean PA pressure normally is around 14 plus minus 3, so most of the time is below that. In children, also the same with after the 3 months of the age when they are reaching the adult type issue. With the complexity of the factor in the children, we have a chromosomal and genetic syndromes, and really we have a lot of Down syndromes in our field of pulmonary hypertensions, other genetics, which is we don't know underlying causes, plus the heritable type of PH. Pathological insult is growing. It's because of, can be insulted because of prematurity, insulted because of chronic refluxes, recurrent infections, other metabolic under causes. And developmental lung also, they have, we'll talk about it, but there is a lot of developmental lung abnormalities, which can be as variable from lung hypoplasia to absent lung to interstitial lung diseases and others. Multifactorial conditions that which can combine all the things. Sometimes you have prematurity, congenital heart diseases, and other genetic syndromes. So it's not the easiest way to define these things, and you have to figure out what is the most contributing factor for pulmonary hypertension. In the pediatrics, we, as I mentioned, because we are slightly different from the adult, we have transient type, which is transient type that pH is resolved and it's a cure, and it is happening in 80% of our children. And most common is the persistent pulmonary hypertension of the newborn, congenital heart diseases, which is operated, and most of them they resolve. Upper airway obstructions, and usually in children in the age of between 1 year and 4 years, they have upper airway obstructions. And after adenotonsillectomy, most of them they improving. Some of the patients they have trachobronchial malacia, and that's also they improve with time. The other group is undetermined. Some of them they progress to progressive pulmonary hypertension, and some of them they resolve, like congenital and acquired lung diseases. And some of patients post-operative congenital heart diseases, some of them they resolve and then they recur and progress to as a progressive pulmonary hypertension. Down syndrome, which is really also another, it was classified as group 3, but in the same time, in their classification for group 3, some of them they have pulmonary hypertension with congenital heart disease, some of them because of the lung diseases, and some of them they improve and some they get worse. The progressive type of pulmonary hypertension, which is around 5%, which is they call it pulmonary arterial hypertension, which is the group 1. Then post-capillary, which is the left-sided heart, and it is counted for around another 5%. And this is very important, which is differentiating the pulmonary hypertension in children from the adult, because adult most of the time, if they have pulmonary hypertension, they will progress with this, whereas the children, some of them they can cure. In this study, it was a very famous study of 15 years registry in the Netherlands. You see that most of them, 82 is patient is transient type. The other after the transient type is the lung diseases, and this is very important playing factor in children with pulmonary hypertensions. That after that is the left heart and the progressive type of pulmonary hypertension. So in the classification, which is mentioned by almost all the Dr. Hissam and our speakers, Dr. Hissam and Shaya and Abdullah, that they classify, they group them in because of pathophysiology and in uses of advanced pH therapy. So it's, if the patient, if this group is having the same pathology, they put them in the group, in the same group. And that's why you see that even in the group 1, they are heterogeneous type. And if you can use advanced therapy, that usually they put them in group 1. If in BPHN is there, but you know that BPHN, they don't have much pathological changes comparing like to the what's idiopathic, but we can use the advanced therapy. So BPHN, persistent pulmonary hypertension of the newborn, was put there with the same group. And that's what I will show you here. And this is the same table, which is my colleagues show you, that there are group 1, which is all sharing that they can use all advanced therapy, and they are having the same pathological changes if we are taking this persistent pulmonary hypertension of the newborn from them. Also the pH with the pulmonary veno-occlusive diseases, it was put with them because of the changes, but you know that with this type of diseases, we are avoiding using of advanced therapy, and sometimes this patient worsening with advanced therapy. Or it should be used with them in precocious type of the diseases. And this is also, they have a lot of subclasses for the pulmonary veno-occlusive diseases. It's beyond the scope of this lectures. The left heart is, we are having the same with the adult, but most of our left heart diseases is a congenital type, and most of them is operable, and usually they improving after that. The other important thing is the hypoxia related and or developmental lung diseases. I will give a small talk about it more, but it's very important. We can have obstructive lung diseases, restrictive, other lung diseases of mixed hypoxia without the lung diseases, with upper airway obstructions or any causes, or high altitude. Pulmonary artery obstruction, chronic thromboembolic, if you see that previous study, is only 5 patients was diagnosed over 15 years. But the most common with us is the pulmonary artery obstructions, and usually is a congenital because of peripheral stenosis, disconnected pulmonary artery, and others. The same is with the other 5 groups, and this is very important to know it. It's like because of hematological and systemic diseases. We put a complex congenital heart diseases, including the single ventricle pathway with the group 5, until we will sort it out. And usually, you know, that is usually still the literature is coming with uses of pulmonary vasodilators in that single ventricle. When I'm talking about the group 3, and the most important in the group 3 is the developmental lung diseases. And that this is because of most of the children, most of the pulmonary hypertension children, which is progressing, is because of lung diseases, is more than congenital heart diseases. But it's very important that the developmental lung diseases should be excluded. And this is what should be a cooperation between the cardiologist and pulmonologist. I put all this number, and you see this eight subcategories of the developmental lung diseases. And you see that the most important is bronchopulmonary dysplasia, because of most of the premature baby, they can suffer from the bronchopulmonary dysplasia. Congenital diaphragmatic hernia, this is another one. Lung hypoplasia is the other third important. The other is also rare diseases, but it's not a thing which is not happening, and you should be careful. And when you have this type of patient, you should make sure that the pulmonologist see the patient and assisting him before going more further to be as labeled as idiopathic. Congenital heart diseases is very important in childhood, and it's also in the adulthood. But when we're talking about the congenital heart disease, pulmonary hypertension can present with cyanotic heart diseases and can present with non-cyanotic heart diseases. It's very important because the people, they think that patient with cyanosis, sometimes they will not have it. But the most important is to know it in the small children is BPHN with detransposition and intact symptoms. And this is usually playing a major mortality in this type of groups. And this patient of a group that we do septicemia for them, and they never improved. And usually they improved as if you start to recognize them and you treat them as BPHN. Although they are cyanotic heart, you do septicemia, you do start prostaglandin and statin nitric oxide until the patient condition is improving and return back. Then you know that you are dealing with it. It's around 5 to 10% in some of the series with the TGA intact symptom. Hypoplastic left heart syndrome is very important also, and especially if the patient have restricted patent foramen or falls or small AST. tetralogy fault with absent fault is usually another patient with having also pulmonary hypertension, but usually because of that, this patient, they have lung diseases associated with pulmonary tetralogy fault with absent valve, and you know that because of this, they have high pulmonary BA pressure. With non-cyanotics, you know, all of you, that is PST, AST, BDA, and it's dependent on that is pre-tricuspid is developing the pulmonary hypertension in the later age, post-tricuspid, they develop it in earlier stage. The abnormality of pulmonary artery, which is I want to mention, is also disconnected BAs, hypoplasia, peripheral pulmonary stenosis, and others. And we put them in group 4. And usually this type of patient, they improve when you're starting them and you do surgery for them, or you do intervention if they are amenable for the intervention like balloon angioplasty or stenting. Eisenmenger syndrome can be in cyanotic heart and can be in non-cyanotic heart. So be careful sometime of the patient with cyanosis, like transposition. We know they are developing transposition intact symptoms, transposition with VST, double outright right ventricles. Sometimes all this complex heart diseases, which is have cyanosis, they can have Eisenmengers, and their cyanosis will continue, worsening of their cyanosis with time. And usually you need to realize this earlier and do surgery before they go to the Eisenmenger. We know that most of the worst thing is the patient with truncus arteriosus, which is a cyanotic heart diseases, which can develop pulmonary Eisenmenger syndromes in early life, in the first year of life. And this is very important to realize and do their operation before. Post-cardiac surgery, you have two things. Patient can have developed hypertensive pulmonary hypertension crisis, or you can have a persistent pulmonary hypertension, or sometimes the pulmonary hypertension resolve and later on, after a few months to a few years, they return back and they progress to as idiopathic type. We need to do a cardiac catheterization in a selective patient, of the patient who is query operable or not, or the patient who is idiopathic, and we should make a good decision, because the cardiac cath in children, we are doing it most of the time under general anesthesia, and patients under general anesthesia with pulmonary hypertension carry high risk of pulmonary hypertension crisis and death. The pathophysiology, as you know, that it's endothelial dysfunction, and when you have endothelial dysfunction, you have endothelial cell proliferation and vascular remodeling, and this usually started from vasoconstrictions to hyperplasia to intimal formations, plexiform lesions, and obstruction all, and degeneration of the vessels. So that this is the pathway in the pulmonary arterial hypertensions. And it's expected to have the most common three pathway, which is my colleague talk about their treatment, is the endothelial pathway, nitric oxide pathway, and prostacyclin pathway. And this is the target of medication nowadays. They have in the endothelial pathway, there is increased secretion of endothelial. In nitric oxide pathway, there is decreased secretion of nitric oxide. Or synthesis, prostacyclin pathway, there is also decreases in the pathway, and that's why we have imbalance between vasoconstriction and vasodilator. So the nitric oxide and prostacyclin is vasodilator, endothelin is the vasoconstrictions. So when we are suspecting in the children, when we have also, there is no specific signs and symptoms, you have to suspect it when there is underlying causes which can cause this, like prematurity, chronic lung diseases, congenital heart diseases, connective tissue diseases. Also, I want to mention that it's very rare in connective tissue disease in children, and rarely we find in some of the patients with SLE. Patient with portal hypertension or upper airway obstructions, patient with unexplained dyspnea, unexplained syncope, unexplained seizures, unexplained failure to thrive, unexplained decrease in the activity. Also, if you have unexplained improvement in congenital heart disease, heart failure, if they are improving, this patient has started developing pulmonary hypertension and they're reducing their shunt. Unexplained chest and abdominal pain is very important. If you have high liver enzyme, pro-BNP or BNP, lung function test abnormality, unexplained sudden death, all can be the causes caused by pulmonary hypertension. We have to look for the growth parameter. Usually they are failure to thrive and below the normal. If they have edema or ascites for no explanations, loud second heart sound, systolic and diastolic murmur, the distended neck veins, cold extremity, and this is the end stage, hepatomegaly and splenomegaly, and hypoxia, cyanosis, and clubbing. This is very important, non-specific pulmonary hypertension, but if you find any of them, you have to think, if you have no good explanation, you should put in your mind pulmonary hypertension. Of course, we have easier way, do ECG, do chest X-ray and echo. Doing ECG, you will find the right ventricular hypertrophy or right atrial enlargement. Chest X-ray is usually cardiomegaly or dilated pulmonary arteries. Echo, if you do good echo, you will know that there is a pulmonary hypertension or not. You do detail. If you do ECG, chest X-ray, and echo, you will not miss any patient with pulmonary hypertension. This is the three is usually is enough to diagnose or exclude pulmonary hypertension. So management, I put this as a guideline. If you can treat underlying diseases, if possible, is the best way. If it's a transient, like BPHN, you'll use your nitric oxide and sildenafil. If it's shunt related or left-hearted heart, you have to do that in appropriate time. Do the surgery. Chronic lung diseases with mild BHs, you need the lung therapies. Upper airway obstruction, we need to treat the underlying causes. Lung disease with moderate to severe type, like bronchopulmonary dysplasia, scimitar, absent right lung, maybe you use the advanced therapy. Disconnected BA, you need to do surgery. If you have a progressive type, like idiopathic or heritable type, or congenital heart disease associated non-operable, then you are using the advanced therapy. Portopulmonary BH and the connective tissue disease is very rare in children. Chronic lung disease with severe BH, sometimes they progress very fastly and they go on right heart failure. It's very rarely to find a lung transplant in children. Non-operable congenital or acquired heart diseases, you have to deal with them as like a cardiology. I put this diagrams to simplify the issues, but when you are having a transient type, you look for the causes, and if you can solve it with surgery, with a therapy or underlying causes treatment or medical treatment. And the progressive type, if it's pulmonary BAH, you treat with advanced therapy and you control that. Using of one medication in children is sometimes not enough. Most of the time we try to use more than one because of the progressive diseases and aggressive type. And when the patient is improving, we sometimes keep them in 2 to 3 medications. If the patient with transient type and they are improving, then we start to wean the medication and we off it. The same other general measures for children. You have to have good nutrition, vaccination, plus the RSV and influenza, pneumococcal, treat anemia, do exercise with no competitive sport. Hypoxia, provide them with oxygen. Don't allow hypoxia unless the patient has cyanotic heart disease. Health and general education for self-care. General school education if you can, and try to help them if they can have often 1 or 2 days attending the school. Psychological support for the child and his family is very important. The medication which is mentioned by Dr. Shaya, this is the same thing we are using for them. Usually we are using the phosphodiesterase, and we are using endothelial receptors. Prostacyclin also we are using them. Selexibag is in children still not common, but usually we are using it after 10 years of age. The same thing with other endothelial receptor like mesentans. And this is very important to know that we are using the same thing of the adult medications when the patient age is allowed. So thank you very much. And thank you, Dr. Hussam and Dr. Shaya and Dr. Abdullah for invitation and allowing us to share with you.
Thank you so much, Dr. Omar. Thank you for the attendance. Actually, we had more than 1,000 attendees on the panel, and I think there's some more on the YouTube platform. I hope that this has led to improve awareness and increase general knowledge about pH. The message here is that we are around here for you. If you have a patient whom you suspect that they have pH, we are very happy and willing to help you take care of them, whether you refer them or you can call upon us for consultation or questions. There were a lot of questions through the chat, and I hope I managed to answer all of them. If there is more questions, some of you had more than one questions, that obviously showing signs of interest. And if you need further information or more interaction, we're happy to do that through the sponsor. I think they can make arrangements to have direct contact with us. Thank you, Abdullah. Thank you, Shaya. Thank you, Bayer, for organizing it. And mainly thank you, attendees, for being with us until the last minute. Like this, we call this as pH Aware, and hopefully this program will be continuous to increase awareness amongst other groups of general practitioners, even subspecialty areas where it is needed. So we are right on time. I think I will go ahead and conclude our meeting. Thank you all, and Ramadan is coming, so كل عام وأنتم بخير. تقبل الله طاعاتكم, and inshallah we'll see you around soon in another educational activity. السلام عليكم.
Thank you very much. شكرا. السلام عليكم. في أمان الله.
التوفيق جميعا. شكرا لكم.
Thank you.